Hey everybody, Dr. Jess. How you doing? I'm here on Cape Cod, Massachusetts, and we are just recovering from a blizzard. Not really a blizzard, more of a cyclone with 2.5 feet of snow and 60-mile-an-hour winds. Interesting to say the least. But this week on The Answers, we are going to talk about mood and behavior disorders and the basis of them, because I'd like you to understand what is going on if you have anxiety or depression or the like. And I'm only going to do that. I'm going to do this in parts because otherwise we'll be here all day. And I promise to do little snippets. So here we go. And we have slideshow from the beginning. Okay, why are we so moody? Part 1. Okay, so what are we going to learn today? We're going to learn what creates mood and behavior issues. What are some of the root causes of it? And why this information is so very important to you. Again, I'm going to tell you right now. Why is this important? Because we, and I do mean practitioners, our attitudes towards mental illness has caused people to suffer in silence. I treat a lot of mental illness. And I have to tell you something, these are the best people in the world. They have a crummy disease, but they're the best people in the world. They're not lazy, they're not a weakness of stock, but what we call them, how we approach them, how traditional medicine approaches them is a stigma. It breaks their spirit, and this stigma must end. And I want you to walk away with this point right now. All mental illness of whatever ilk is physiologic. Mental illness is not laziness, it's not weakness, it's not a weakness of character, nor is it desirable. I know a lot of people with this type of illness of whatever level, they don't want to be like this, okay? And what we must do as practitioners and as a society is discover and resolve the root causes, okay? Because there are root causes to mental illness. Okay, remember that, you might remember, but I'm teaching you now, that moods and behaviors are an expression of the neurotransmitter balance in your brain. So if you look at the graphic here, you'll see that things like serotonin, norepinephrine, dopamine, they all have their individual functions and where it concerns mood. But when you put them together, you can have mood, cognitive function, appetite, sex, aggression, so forth and so on. Okay. In other words, it's the balance of neurotransmitters that is necessary to maintain either poor moods or behaviors or good moods and behaviors. There's lots and lots and lots of things that affect mood and behavior disorders. And I'm not going to go through all of them today because we're talking about low blood sugar, methylation, essential fatty acid deficiency, and so forth. We're going to talk just today about neurotransmitters. So what are these bad boys? Neurotransmitters are chemicals that transmit neurological information across, there's a space in between the nerves called the synapse, okay? And the information that comes down the nerve has to cross here and go over to receptors on the other sides. So they're chemical messengers that carry information across the synapse. And that synapse can go to anywhere. So it could be from nerve to nerve, it could be from nerve to muscle, it could be from nerve to gland cell. So it affects everything. Another thing you should know is that the neurotransmitters, the chemicals themselves, are stored inside things called vesicles. Think of them as warehouses. And you need good membrane stability to store them and be able to transmit neurotransmitters correctly. And that's something we're going to cover next week. So neurotransmitters are basically in two categories, either excitatory or inhibitory. The excitatory neurotransmitters, and I want you to think of these guys as the things that keep you awake and give you energy and allow you to focus, okay? So here's an easy chart, and you have adrenaline or epinephrine. And like anything else, if it's too high or too low, there's problems. If it's too low, you're going to be fatigued, you're going to have lower focus, you're going to start gaining weight for no reason. If it's too high, you're going to have difficulty sleeping, anxiety, tremors, hypertension. Same thing with norepinephrine, except norepinephrine is more specific for your ability to focus, as is on the other side, PEA, phenylethylamine, If you have low norepinephrine and low phenylethylamine, you're going to have ADD. Okay. And it's not, you just don't feel like doing it. You're simply going to have ADD if you don't have those two neurotransmitters at proper levels. Dopamine at the top there, which you hear a lot of, is kind of a funny neurotransmitter. And I don't mean funny, haha, I mean funny, strange. When it's in its normal amounts, it is your neurotransmitter of satiety. Okay, so when you get a good feeling like, oh yeah, that's dopamine. But if dopamine drops below a certain point, you can get a very deep depression. And that depression is called Anadonia. And you notice it by a lack of joy. So when that person's depressed and just, things that used to give them joy don't anymore. Okay. You're at a low dopamine level. This isn't like absolutely etched in stone. It's very complex. Okay. When dopamine goes high, okay, you can have cell death, you can have cravings, you can have developmental delays, you can have poor intestinal function, you can have psychosis. So let me give you an example. There was a company that I used a while ago to measure neurotransmitters. Okay. And I'm going to, here it goes. And if the high for dopamine was 190, you would see around 250, 300, you'd see paranoia, excitation, things like, just the person not being themselves. In the 400 range, you'd start seeing psychosis. And all of my autistic children, every single one of them had dopamines over 600. And if you're wondering why the frank autistic, those kids that are really out there are like this, they cannot form thoughts. They cannot actually form the thoughts because of the high dopamine. Glutamate is another excitatory neurotransmitter that when it's high can cause cell death, seizures, brain damage. There is an enzyme called glutamate carboxylase, GAD, that takes glutamate and turns it into GABA, which is the usual reason why this is very high. And that's why sometimes when I'm working with somebody and we're trying to fix a gut, often glutamine is involved. And I usually don't use it because glutamine becomes glutamate. And if there's any problem with that enzyme, the glutamine is going to create more glutamate. And it's like throwing itching powder down somebody's back. Now, inhibitory neurotransmitters are those things that calm you down, okay? The one you know the most of is serotonin, okay? And if it's low, you might have anxiety, insomnia, depression, uncontrolled appetite, like me, usually for sugars or carbs, headaches, and unexplained GI symptoms. Well, some things you don't know about serotonin, okay? That if you eat potatoes and stuff like that, one of the reasons you might feel really good about it is because it gives you a shot of serotonin. And 80% of the serotonin in your body is made in the gut because the gut's nervous system, called the enteric nervous system, uses serotonin primarily as its neurotransmitter. So it's real important in the gut. If serotonin is too high, and I really do mean too high, this is where you might see road rage, hot flashes, serotonin syndrome, irritability. Many women who have hot flashes during the perimenopausal or menopausal areas find that their doctors will give them an SSRI, a serotonin reuptake inhibitor, to raise the serotonin at the synapse, okay? Because serotonin is kind of what runs the thermogenic system. And this can be done naturally, of course. The other biggie is GABA, gamma-aminobutyric acid. And if you have enough, you can calm and sleep. If you don't have enough, anxiety, insomnia, tremors. Now, generally speaking, when it's prescribed as a medicine, you're given a benzodiazepine, Valium, Xanax, Klonopin, Ativan, and so forth. Also, alcohol, when you first drink it, will stimulate, just like these other guys, the GABA A receptor to release GABA. Problem is, it's like the McDonald's off the highway, fast on, fast off, okay? So you tend to have a lot more of it or repeatedly, otherwise you're not getting your GABA. If you have a GABA B receptor stimulator or agonist, okay, tends to stay on longer and work better. These are not readily available. There was something called phenylated GABA. There we go again. Phenylated GABA, which is called Phenibut, but it's no longer available anywhere. It worked very, very well, but we won't get into it. Okay. The one GABA you can get is, there's lots of GABAs out there, but I'm very big on crossing the blood-brain barrier. So if GABA is working for you, the normal GABAs, pharma-GABA, and so forth, all power to you. But for the most part, I like a liposomal product, and I know Quicksilver Scientific does sell something like that. So your moods, balance is the key. And serotonin and dopamine is the happiness tour. You need a balance of serotonin and dopamine in order to feel like yourself, okay? And what causes this to go awry? Stress or stressors that will accelerate the neurotransmitter depletion or imbalances. Let me show you exactly how it works, okay? There's a bit of an animation. We're just going to talk about dopamine here, okay? Oh, by the way, I wonder what causes the neurotransmitter levels to go off. Yeah, have you guys seen this before? Like last week, okay? All the things that cause the cell danger response can result in neurotransmitter levels being imbalanced. So, as I promised, an animation. So in the middle of the nerve there, you see tyrosine that becomes dopa, then dopamine. The dopamine, the little blue circles, go into the vesicles, which is where they are stored. If they're broken down inside the nerve, they're broken down by MAO, okay? When the body needs dopamine in the synapse, it'll call it this. The vesicles will go down and release some, and then the dopamine will go over to the receptors on the other side. And when the message is given, okay, the dopamine will pop off the receptors and do one of a couple of things. It'll either get broken down by COMT or hang out with its buddies or get reabsorbed in a reuptake mechanism. So when you look at something like this, you see optimal activity and the stores are full. Now, if we looked at it on a graph, you'd see that the optimal range, where the neurotransmitter stores are in the optimal range and the neurotransmitter activity looks good. But now you encounter a stressor, okay? And there's an increased need for neurotransmitters, an increased demand for it. And you can meet that. If your vesicles, if your warehouses are full, you can call on them and you'll have high activity and you'll be all right, okay? You don't feel this. Your body takes care of it, okay? And if you looked at it on a graph, okay, the neurotransmitter stores would be dropping, but they're still in the optimal range. Okay, but the neurotransmitter activity is quite high. Chronic stress. Neurotransmitters simply aren't made as quickly as they're needed. So the stores will still decrease, although you will have optimal looking activity at the synapse. And guess what? You don't even feel this. Okay, you don't know that these stores are decreasing, only that you have chronic stress and your body's compensating for it. On a graph, it looks like this. The neurotransmitter activity is dropping, but it's still in the optimal range. The stores are dropping, okay? And again, you don't feel this. When the neurotransmitter stores become depleted, this is when you get your symptoms, okay? You have low activity and not enough neurotransmitters to transmit the information. And when that happens, okay, that's when you get symptoms, whatever it happens to be, whether it's depression, anxiety, whatever it happens to be, this is the stages which it happens. And if we put it on a graph, it would look like this. Okay, everything's low, and this is where symptom development takes place. Now, when you're given a reuptake inhibitor, let's talk about a serotonin reuptake inhibitor or a dopamine reuptake inhibitor, what's happening here, and I'm going to go backwards a little bit, is that you get this optimal looking activity because some of the neurotransmitters not being allowed to go back into the nerve. But what it doesn't do is supply you with the target neurotransmitter. In other words, an SSRI is not giving you serotonin. An NRI is not giving you epinephrine, norepinephrine. And as DRI is not giving you dopamine. So really, if this process is going on, it's doomed to fail, okay? And honestly, it takes years to get to this point. If you'll notice the graph, that time in the bottom is months and years. So this is why traditional medicine fails. You go into your doctor, and I'm not complaining about the doctors, okay? All right, they're doing the job. With primary complaints of depression and anxiety, and this is what normally happens. You'll be given an antidepressant, generally speaking, an SSRI, because serotonin is the usual thing that's low. Okay, if that doesn't work after 4 weeks, they'll increase the dosage. If that doesn't work after 4 to 6 weeks, they'll change medicines. If that doesn't work after 4 to 6 weeks, they'll increase the dosage of that. And after a while, maybe they'll change the medicine around to, let's say, something like Wellbutrin, which is an SNRI and SDRI, which works on raising serotonin and norepinephrine. And maybe that will work, or a combination of them will work. And if they don't, we're now 6 months down the road. Okay, you'll be referred to a psychiatrist for atypical antipsychotics, which are even stronger and more complex. And here's the result. If these things do not control your symptoms, you are heading for polypharmacy. In other words, taking a lot of medicines, because these medications do not get at the cause or even the true effect of the issue. So they're not getting at the reason for the original reason for the neurotransmitter imbalance, and it's not supplying you with neurotransmitters, okay? Even in the atypical antipsychotic range, after a while, you simply don't have what you need to reuptake or to it block or whatever. If you don't have it, you don't have it. Okay, and these medicines do not produce neurotransmitters. They simply attempt to control them. Okay, so what do you do in cases like this? What do you do when you don't know what to do? Well, Sir William Osler, who was one of the founding fathers of Johns Hopkins, said, listen to your patient. He's telling you the diagnosis. Remember last week I told you about, picking out a practitioner, get somebody who listens to you. Well, everybody thinks, because I do a lot of listening, and that's the way I work, that, I'm doing this fantastically new thing. I'm doing something fantastically old. Dr. Osler said this in 1895. Okay, listen to your patient. He's telling you the diagnosis. And the way things are these days, doctors don't have the time to listen. And that's why you do need to find a practitioner who will take the time to listen to you, because you take a good history, you'll find out what the root causes are, you can follow it along, and guess what? You'll get some answers. Why? Because mood disorders and behavior disorders, not only is it neurotransmitters, you have to consider causes of inflammation, the integrity of the cell membrane, mitochondrial function, nutritional deficiencies, genetic polymorphisms, nutrigenomic, and a whole lot more stuff. It's not as simple as I just made it. I only talked about one aspect. So you need somebody who thinks like a detective. I wonder who that might be. Okay, seriously, you need somebody who will think this out with you. If the simple stuff hasn't worked, like when you go to Dirty Jeans and you do your soak and scrub and spot cleaning and all this good stuff, if that doesn't resolve your condition, then you need somebody to dive in who can think like a detective. So again, I'm trying to make these things short so that, we're not taking up too much of your time, and, your attention span is good. And I will continue giving you bits and snippets each week of the answers to your actual health problems. If you have a chronic disease, if you have a problem that hasn't been figured out, okay, you can call my office, you can contact me, and I'll give you a 30-minute get acquainted session. We can see what we can do for you. And if you'd like to know more about neurotransmitters, you can go to tinyurl.com/brain/wall. This is the brain wall, okay, where it's all color coded about what parts of the brain work and how they work and what neurotransmitters they use. And you can actually listen to somebody and get a really good idea of where the imbalances are. Obviously you have this in front of you, but this is my son's work. And, if somebody wanted I have a very large poster of this on my wall. If anybody was looking for something like that, just contact me and I will give you the link to actually buy the poster. Okay. And it's really wonderful if you're explaining stuff to patients. But if you go to this video, it explains the brain wall. It's about a 15-minute video. Okay. And I think you'll like it. So that's all for this week. Okay. I hope you learned something. Okay. And we'll continue giving you little snippets of information, 15-20 minutes long, okay, to answer the issues that concern you the most. And right now, what I would like to do is ask anybody to send me emails. Okay, you can send it to me on Facebook, on Instagram, and let me know what your concerns are, what conditions, what things you can't resolve, okay, so that I can start addressing them, okay, in these podcasts, okay? Thank you so much for your attention. I'm going to hit the stop share thing here and say, have a good week. Take care now.